Hi, everyone, and welcome to the Pulmonary Hypertension Association's PHA Classroom e-learning event series. I'm extremely pleased to present today's webinar, Living My New Normal. My name is Rihanna Rivas Morello. I'm the Medical Education Program Manager at PHA, and I will be moderating today's event. Today's program will consist of a presentation by Natalie Kitterman, followed by a brief question and answer period. During the call, all lines will be muted, but if you have a question, feel free to submit it using the chat function at any point during the presentation. You can also ask questions aloud by using the raise hand function on the web interface later in the call. At the conclusion of the presentation, please take a few moments to fill out the brief evaluation that will pop up in your internet browser once you've closed out of the webinar. We truly value your feedback and use it to shape future PHA programs. So, without further ado, allow me to introduce our presenter who has graciously volunteered her time to lead this presentation for us today. Natalie Kitterman has worked for Intermountain Healthcare for the past 35 years and has worked exclusively with adult PAH patients for the past 25 years in the Pulmonary and Critical Care Medicine Division. She helped Dr. Gregory Elliott develop the PAH Center in 1994. Natalie has expertise in both clinical and research trial management and many years of experience in inpatient and outpatient case management and protocol and educational material development of this complex patient population. Natalie has been involved in PHA's PH Professional Network, also known as PHPN, since its inception and served as its first chair from 2004 to 2006, when she also served as a liaison to PHA's Scientific Leadership Council and as a PHA board member. She later also served as a liaison to the PHA Corporate Committee. Natalie currently serves on PHA's PHPN Education and Practice Committees, PHCC Review Committee, and Early Diagnosis Committee. She founded and organized the first PAH support group in Salt Lake City, Utah, and continues to function as one of its leaders. In 2011, Natalie was awarded the Nurse Excellence Award from Intermountain Healthcare. So, with that, welcome, Natalie. Thank you so much for taking the time to lead this presentation today, and the floor is yours.
Thank you, Brianna, and welcome to everyone who's on the line and on the computer. Hope you can all hear me. If you can't, let us know. So we're going to start with living and finding your new normal. Okay, so our learning objectives today are we're going to learn about what pulmonary arterial hypertension is, or what we refer to as PAH, and I may refer to that as well as pulmonary arterial hypertension in the slide set. We're also going to be learning about how PAH is diagnosed, and we're going to learn some important things for you to know, as well as what you can do to help yourself and your significant others, especially in this disease process and through your journey. And then we're going to learn a little bit about how you can cope with your new normal. So the definition of pulmonary arterial hypertension, or PAH, is resting mean pulmonary artery pressure that is greater than or equal to 25 millimeters of mercury. So we often refer to this disease as the other high blood pressure. So like your systemic high blood pressure, this one is specifically in the lungs. So some physical changes that you might see, that we see with pulmonary hypertension, pulmonary arterial hypertension, is it is basically a disease of the vessels of the lungs. So you can see here, I'm going to get my arrow, that in a healthy vessel, the inside of the vessel is wide open and blood can flow freely. So you can see the blood flowing freely. In the pulmonary arterial hypertension vessel, it becomes damaged from a variety of a number of processes. And as the vessels become damaged, the inside area of the vessel becomes thicker, and in severe pulmonary hypertension can completely block the entire vessel so that there's no blood flow. So you can see the reduced blood flow. as these vessels become damaged and blocked and the pressure increases in the circulatory system, that causes the right heart to have to work harder. Over time, the right heart becomes more muscular and it can't pump as well and eventually wears out. For instance, we refer to it as chronic heart failure. If you think about lifting a 5-pound dumbbell with your arm versus a 50-pound dumbbell, there's the difference. So a low pressure would be lifting that 5 pounds, and it's very easy to do several reps with that. But a 50-pound weight would take a lot more effort, and you would tire out a lot faster. So when the heart doesn't work as it should, it affects the whole body, since the heart pumps vital oxygen to all the body organs. So it's important for that heart to pump properly if it can. So some symptoms that you might have all experienced, you might have experienced one or all of those. You can see on here the shortness of breath, or what we call dyspnea, chest pain, which we call angina. You could also see swollen ankles and legs, as well as swollen in your abdomen area. We call that edema. You can also have experienced fatigue or feeling tired or worn out. And some people experience dizziness and lightheadedness and even faint, which we call syncope. Since these symptoms are what we call vague, or it can be experienced in many disease processes, it is hard to distinguish pulmonary arterial hypertension from other diseases. PAH is a rare disease affecting about 1 in 100,000 patients. So if you think about the population of the United States, that's still considered pretty rare. Thus, I think why the bulk of the population seen by healthcare teams, PAH is not the first thought. It's kind of like jumping from A to Z rather than jumping from A to B. So we are all unique, and our symptoms can vary between ourselves and others, as well as between the cause of a person's pulmonary arterial hypertension or why you have the disease. And we really can't compare our disease with other patients, specifically since we are unique. It's almost like comparing apples to oranges. So we've got to make sure that when we talk about ourselves to others, that we're really talking about the same thing. So syncope, of course, or passing out or feeling like you're fainting or fainting is a symptom that is concerning and should really be taken serious. So in diagnosing pulmonary arterial hypertension, this slide can show you that PAH, or pulmonary hypertension, is a big banner under which several different disease processes are under that big banner. And then below that, specifically, we're going to be talking about this WHO Group 1. So PH is that big banner, which we talked about. Pulmonary hypertension is a broader definition, which is an increase in the pulmonary pressures, which can be caused by these different disease groups. Pulmonary hypertension and pulmonary arterial hypertension are not interchangeable, so they're not one and the same, but they are kind of a bigger picture and a smaller picture, if you think of it that way. So it's imperative to distinguish what the cause of a person's pulmonary hypertension is. Obviously, diagnosis should always drive treatment. So WHO, if you see that in this slide set here, the WHO group, WHO actually stands for World Health Organization. So WHO Group 1 is PAH related to vessel disease of the lungs. WHO Group 2 is related to left heart disease. Group 3 is related to other lung diseases like interstitial pulmonary fibrosis, which it usually involves more the tissue of the lungs rather than the vessel of the lungs. Group 4 is related to chronic blood clots in the lungs. We refer to that as CTEPH. And Group 5 is related to multiple factors for multiple diseases. It's kind of a mix and a bag. So we're going to kind of focus today, of course, on WHO Group 1, or pulmonary arterial hypertension. And even within that, there are other classifications. And we're just going to go through those real quick. So if you can look in the red piece of that box, you can see that within the WHO Group 1, the classifications are first, idiopathic, and that is basically unknown. We've gone through all of the testing that we do, and we can't really find a reason why you would have pulmonary arterial hypertension. The next one is a classification called heritable, or it used to be called familial. It's basically a genetic piece of PAH, and that's related to families. And that's more rare, but there are several families who have affected members in 2 or 3 generations. The third one is related to drugs and toxins. So if you can remember in the fen-phen day, that era between 1990 and in the year 2000, that drug we see helped, or it caused pulmonary arterial hypertension, as well as some disease, some damage of the valves of the heart. But today we don't see so much fen-phen, obviously, but we do see quite a bit of methamphetamine abuse. So that is also a PAH related to drugs and toxins. Then the next category is called associated, or APAH, and that is our biggest category. It includes and incorporates several different disease processes, like the autoimmune disease like scleroderma or lupus. It also incorporates heart defects, or congenital defects, and liver disease. The last category is pulmonary veno-occlusive disease, or pulmonary capillary hemangiomatosis, some very big words. But what these diseases are still vessel diseases of the lungs, but it's even more rare than PAH. So functional classification, it's kind of, you can see here there are class 1, 2, 3, and 4. And those classes we'll talk a little bit about. It's kind of interesting. We have 2 WHO. If you can see the WHO functional group up here, it's a WHO functional classification, so we're not talking about classifying pulmonary arterial hypertension or other forms of PH. We're actually talking about the way people can function. So it's a little confusing, but we're kind of switching gears to basically functional ability. We determine this functional ability in 2 ways. So we listen to what you tell us and what you feel you can or can't do, which helps us to fit your abilities into the above definitions. And the other is having you perform a 6-minute walk test. So I would say most of our PAH patients that we see come to us in either group 3 and 4. Most of our patients live in that WHO functional group 3. So 1 would be you could run the stairs, you could do anything you basically wanted to. 4 being you're short of breath at rest. And that kind of gives you an idea of where people fit. So it's an important piece of your evaluation, which we do at each clinic visit. We need to know whether you can do more with less breathlessness. It helps us to gauge whether the medications we are prescribing are working, or whether we need to add more oral medications or inhaled therapies, or maybe even move to our more potent therapies that are administered subcutaneous or intravenous. So, of course, our goal is to improve your functional class with the therapies we prescribe you. So if you come to us at a group 3, we really want to try and improve that to a group 2 or group 1 if we can. So some diagnostic testing. We're going to talk a little bit about pulmonary function testing, echocardiogram, some imaging, as well as our right heart catheterization. So PAH, if you can remember, is the diagnosis of exclusion, which means that we basically have to do tests to decide what you don't have so that we know what you do have, which is kind of weird and different. So to do a pulmonary arterial hypertension workup requires your patience and help, obviously. We ask you to perform some non-invasive tests. That would be something like, where we don't poke a hole or make a cut in your skin, like an echo. And we also ask you to do some invasive tests, like a right heart cath, where we have to poke the skin and we actually feed a catheter to try and actually measure the pressures that are in your heart. So let's kind of look at the tests and what we call your PAH workup in just a little bit more depth. So the first thing I want to talk about is your pulmonary function testing. Those are also called breathing tests. They tell us how well your bellows, if you can think about it, a bellow that feeds that you would push against to improve a fire, are working. And we also tells us how much air you can move in and out. And it also tells us about how well your lungs process oxygen. So the 6-minute walk provides us with objective data. I know it's the favorite one of most patients, but really with something that we can look objectively. Subjective would be more something that you would tell us. So we can see how well you perform physically. It seems to be the least favorite, like we talked about, for most of our patients, except for those who maybe are the most competitive among us. The walk test provides us with a comparison of you against you. So it's not comparing you with other patients, and that's why it's so valuable. It lets us know whether you are improving against yourself from the previous walk. So if your walk test is lower from the time before, or you are more breathless doing the same distance, we would question whether to add more medications or different medications to the mix of what we've already provided you. Of course, again, our goal is providing you with pH therapies to see if you can walk faster, longer, and with less breathlessness. So we also do an EKG. It's a relatively inexpensive but an important test to look at. It tells us the electrical rhythm of the heart. It can help us identify irregular heart rhythms, as well as provide us with clues, for lack of a better understandable term, about pulmonary arterial hypertension. So the next thing we want to talk about is an echo or an echocardiogram. It is usually one of the first tests that's done on patients, and it's the first test that usually brings patients to a PAH team. The echo is an excellent tool that tells us how well your heart squeezes and relaxes and allows us to see the structures of your heart, so the chambers and the valves. It can also provide us with an estimate of your pulmonary arterial pressure, but it's very important to know that this is just an estimate. To obtain the pressures in your heart and to make the diagnosis of pulmonary arterial hypertension requires a right heart cath. So we also do some blood work. It seems like a lot, but it really gives us some good information about several body processes, about your red blood cells and how well your metabolic panels are looking, and it helps determine if pH is associated with any other diseases, for instance, a low thyroid or some other issue that we can diagnose with blood samples. So the next area is imaging or X-rays. We do this on your chest. We usually do a ventilation perfusion scan or a CT scan. Sometimes we'll do what we call an MRI and or a PET scan. And these provide us with in-depth images of your lungs and your heart. It allows us to determine if you have blood clots, which is a very important thing to rule out, or make sure you don't have, since there is a potential cure for people who have chronic thromboembolic pulmonary hypertension or CTEPH. Those can actually potentially be a cure for patients who have the surgery called a thromboendarterectomy. So the next thing we want to talk about is a right heart catheterization. It's the only way to diagnose pulmonary arterial hypertension and should be performed on all patients. The other testing that is important to perform during the right heart cath is to do what we call a vasoreactivity test. There is a small population, about 5 to 10% of PAH patients who may be what we call vasoreactive, which is usually tested by inhaling a gas. It's called nitric oxide, not to be confused with laughing gas or nitrous oxide, in the cath lab to see if, of course, your patient's pressures can be lowered acutely. If a patient is vasoreactive, the treatment for this type of PAH is a different thing. It's called a calcium channel blocker, which are pills, which are much less expensive than other pH therapies and are usually better tolerated. So the prognosis for patients who are vasoreactive is better, but having said that, not all these patients remain vasoreactive and need to be followed at least yearly with retesting for that vasoreactivity. And if they are not, then they should be reevaluated and a determination made if pulmonary arterial hypertension therapies are warranted. So it is important to complete the test listed above to determine what you truly have, since what diagnosis we provide to you will lead us down different treatment paths. Again, it's diagnosis should always drive treatment. Practitioners, we wouldn't want to put you on a pH medication that wouldn't help you and would maybe potentially make you feel worse, especially if you didn't have pulmonary arterial hypertension. So some non-expert providers who, they rarely see, like some general practitioners, they would rarely see PAH patients in their practices and will usually go down the more common pathways for explaining why a patient is short of breath, such as providing them with a diagnosis of asthma. And I'm sure some of you might have experienced some of that, which some patients, can and do have asthma, and it is definitely more common than pulmonary arterial hypertension. But despite this, there are quite a few patients who are experience seeing several practitioners before a PAH diagnosis is made. And I think this is a common thing experienced in many patients' journeys. So that is why quite a few of our patients take several months to see an expert in pulmonary arterial hypertension, I think. PHA actually has a campaign called the Early Diagnosis Campaign, which is aimed directly at improving awareness and educational tools to help these non-expert providers recognize PAH sooner. So recognizing that, basically the campaign states that if you hear a horse coming down the road, you may sound like a horse and you think it's a horse, but sometimes it could be a zebra. So if you don't know about that campaign, you can get on the PHA website and look that up and help us help your communities. So basically, where do we go from here? What you'll see is a picture of basically a vessel. And this vessel, there are different pathways or areas that affect that vessel. One of those pathways is the endothelial pathway. Another one is the nitric oxide pathway. And the last one is the prostacyclin pathway. So we have identified over the last 25 years that I've been involved in caring for PAH patients that there are these three pathways that affect the vessels of the lungs. The endothelial pathway causes vessels to constrict or get smaller. This happens involuntarily or without your conscious control. So it's like the pupil of your eye. When you shine a bright light into your eye, your pupil will constrict. The nitric oxide pathway dilates vessels. It opens them or relaxes them. But in pulmonary arterial hypertension, the levels of nitric oxide are lower in patients that have PAH. Lastly, the prostacyclin pathway. It is a naturally occurring substance in the vessels of the body which dilates or relaxes vessels as well. This substance is also known to be low in PAH patients. So the therapies that have been discovered to treat PAH are all targeted at these three pathways to either block the vessels from getting smaller or dilating the vessels or helping them to relax so that more blood flow can go through them. This improves that flow and, more importantly, it lowers the pressures in the pulmonary system. So the PAH medications that we currently have, there are 11 therapies to treat PAH today. When I started in 1990, there were no therapies for pulmonary arterial hypertension. Flolan, which is an IV medication, was basically in clinical trials, and if we could use that Flolan compassionate use, which basically means we could get that to try and save a patient's life, we were using that more as a bridge to lung transplantation. But we found the experience of treating these patients with Flolan that it became more of a therapy than a bridge. It really helped these patients, their PAH improve. So that in 1995, Flolan was basically approved as the first drug to try and treat pulmonary arterial hypertension. So, we in those days we had no way of slowing the progression of PAH down. We had to explain to patients that their diagnosis was progressively fatal and it had no known cure. We explained that their average length of life would be about 2.8 years from diagnosis. Today that is very different. Even though PAH is still a progressively fatal disorder with no known cure, with all the therapies that we have been able to impact not only the length of a PAH patient's life, but the quality of their life. So our overall goal is still to find a cure. So if you have to have PAH, I tell patients, now is a good time to have it, as kind of perspective over 25 years of being involved in this area of the disease. So there are lots of people invested from medical teams, specialty pharmacy teams, and pharmaceutical company teams who produce these life-saving therapies that are working hard to help each of you treasure the moments of a better and a longer life. So we also have recognized over the years that I've been in pulmonary hypertension that there are patients who are more low risk or more high risk. So this helps us determine kind of these different values, determine whether you're in a low risk category or a high risk category, and this helps determine which therapies to put you on from the start. So as you can see, if a patient has clinical evidence, see if I can use that pointer again, has clinical evidence of right heart failure, they would be in that high risk category, and if they didn't, they'd be in that low risk category. the progression of their disease. If that is happening gradually or fast, or is progressing fast or rapidly, then we know that you'd be more in a high risk versus a low risk. What your WHO functional class is, so if you're a class 2 or 3, we would put you in a more low risk category. 4 would be more high. And what is your walk distance? So if your walk distance is greater than 380 meters or less than 300 meters, that helps us to categorize where you kind of fit. Also, we do another test called the Brain Natriuretic Peptide, or a BNP, which is excreted by the ventricles of the heart. So the BNP is a blood test. It's kind of gives us a marker of heart failure and where you are. So if that is elevated, then you would have be in the more high risk category. And also the catheterization gives us some measurements, and if those measurements are elevated, we know that you are definitely in a higher risk category. So some of the background therapies, some things that we will put you on that are basically related to treating the varying degrees of heart failure that all of our patients experience. Of course, I'm sure you guys all know about oxygen and how fun that is to wear. You would also know that we put you on diuretics. I have a patient who calls that their pee pills, so at least she knows what they're used for, which is good. And then when we give you those diuretics, because we give them, you will excrete a lot of potassium, so we have to give you supplements of potassium when you are on those diuretics. Some of the other things that patients would be on and we would really like in good control would be sleep apnea. That also will help heart failure, and so if you've been prescribed CPAP or BiPAP, those are important things to maintain or use. And then I just wanted to kind of talk a little bit about some over-the-counters and some herbal preparations. You know, most of those are pretty benign and can be used, and I think can help patients. But please talk to your PH team and get their advice before starting an over-the-counter or using an herbal preparation. And please come prepared with that on your patient medication list, including any teas that you might use, so that we can see if there's any interactions, because there can be interactions with the medications that we are prescribing you. So we really want to know what exactly you put in your mouth. So pulmonary rehabilitation, I love this. Pulmonary rehab, the results will blow you away. Pulmonary rehab is a great way for you to improve your overall health and especially your pulmonary arterial hypertension. It is basically monitored exercise with education provided to you on what you should and should not do when you're exerting. It gives you some parameters and some guidelines. So in the clinical medication trial, so whenever medication is trialed in humans before it is put out on the market, one of the measuring endpoints of those trials is an improved 6-minute walk distance. And in most of these trials, the distances of that 6-minute walk improved somewhere between 20 to 40 meters. In the trials involving pulmonary rehabilitation, the walk distance has improved as much as 100 meters, which is quite impressive. So I think pulmonary rehabilitation or pulmonary rehab is a great part of treating your pulmonary arterial hypertension. I don't think there's a patient that I'm aware of that hasn't derived benefit from doing pulmonary rehab or cardiac rehab if that's the only available option in your area. I would encourage you to speak to your PH team about enrolling in pulmonary rehab. So knowing is half the battle. I think one of the most frustrating or discouraging feelings that I have identified in taking care of patients over these many years is for patients not to know what their problem is, or basically what's wrong with them physically, and then knowing what can be done to help. I really think knowing is half the battle. So the other half, I think, is learning all you can about your disease, educating yourself initially, and then re-educating yourself about PAH advances, taking an active role in your disease process, helping us to help you, identifying the areas that you are struggling in and learning coping skills to deal with them, connecting with others who are going through the same thing you are, monitoring your health and progress. I think the first thing is patients tell me when I ask them how they're doing, their first response is usually fine. So that doesn't give me much information about how you really are doing, how well you walk, how well you're functioning each day. If you're, weren't taking naps and now you are. Those are things that we need to know. So I would suggest to you all that you take and you talk to us honestly about your PAH therapies, about your side effects, about how you're feeling. Allow us to be able to assess completely how you're able to do and what you're struggling with. And we'd also like to know and enjoy any successes you are having as well. So empower yourself to change what is in your control. Knowledge is power. The Pulmonary Hypertension Association has a great website with very extensive and vast amounts of information that are excellent. I would suggest that you take the time to look through that website, as well as they have a nice booklet called the Survival Guide, and that really gives some great information about PAH, what to do with PAH, how to survive it, what medications there are. It's a great resource for you. As well as there's another website called PH Living, which is also got some great information on it. Now you can get on the web, and I tell patients to be careful about the web. You can learn a lot of things that are not necessarily, today's advances in PAH. They might be 20 years old, or they might just completely be totally wrong. So if you read something on the web, don't panic. Just make sure you talk to your providers so that we can basically help you understand what that piece that you're learning about is. So educate yourself about pulmonary hypertension or pulmonary arterial hypertension. You need to ask questions. You need to ask for clarification. There's never a stupid question, I tell my patients. If you are concerned or worried or have an issue, please talk to your nurse and your physician teams and let them know so that we can help you. I think also it's kind of important to learn our lingo a little bit. We have a different language in the medical world. So as I tell patients, when we refer to SOB, which means shortness of breath in my world, that means something completely different in your world. So I think learning that lingo is also a good thing to know so that you kind of know what we're talking about. And if we throw out words that you don't understand, please stop us and say, what is that and what do you mean by that? So the other thing I wanted to tell you at this point was to kind of be careful with free advice. And free advice is free, but I think you'll talk to patients out there or other caring people in your life who will say, well, there's this miracle drug or there's this procedure. So please always talk with your PH team before starting or changing any of your therapies, before going through any procedures, whether they are prescribed or wanted by another physician even. Please make sure you talk to us so that we can help educate you as well as the people who are requesting that. So take an active role in your treatment plan. Be proactive with other healthcare providers and professionals like other physicians and teams, your primary care doctor, your cardiologist. You are the one that can best help us talk to each other and know about you. And I think you basically are the best part of this whole process. And it really, you are always in the driver's seat, is what I tell my patients, and you're the one that can really help us know how to help you. So take an active role in your treatment plan. Know your treatment options. Know what therapies, what medications that are out there for pulmonary arterial hypertension. You should know your medications and why you're taking them. You need to keep an updated list. It's very important to bring that in each time you come to a clinic visit. It's important for us to know what you're putting in your mouth, but then also we can help direct you and educate you on why you're taking those, and I think that's an important thing for you and your caregivers to know. Also talk to your PH team before having the procedures or surgeries so that your risk for having those procedures and surgeries are higher than somebody who doesn't have PAH. So it gives us the opportunity to talk to that professional who may be doing that. So for those women who are still of what we call childbearing potential, birth control is a must. The risk for becoming pregnant and the mortality or the chance of death after carrying and delivering this child is very high. It's at least 50%. So birth control is a must, and for most of the medications you need 2 forms of birth control. So you need to talk to your pulmonary hypertension group about that as well. And then advocate for yourself. You are the best advocator. I have a story of a patient who came into an ER. She had an intravenous line in her chest and a pump, and the physician basically, she asked them to call our team, and they paged me, and the physician was quite upset that, this patient wasn't going to let him completely do all he needed to do for that assessment before he talked to somebody on our team. And basically it was to let them know who you are, what your therapy is, why you have that therapy, and basically to be in the loop to help guide them so that you get the best care possible. So the next thing is to connect or engage with others. It's important, I think, for you to involve your significant others. I think it's a great thing to be involved in the support groups, whether that be locally or nationally or online even now, and also to be involved in the local and national activities and anything to do to promote awareness. You might find that when you go to a local ER or some other physician's office that you probably know more than they do if you are educating yourself. So you are the most important piece of all of this. So how can I help myself? As you can see on here, there are a lot of things that you can do to help yourself. You can take your blood pressures daily and track them. Provide us with those numbers when you come in. That helps us know what your blood pressure is doing with the medications that we give you. Remember, they're dilating, so you will have a drop in your systemic or your regular blood pressure. So we want to know about your fluids. I'm going to talk a little bit, about weight first. So that if you gain weight, that's not uncommon with people who have heart failure. So we want to know about it, at least in our center, if you've gained more than 2 pounds in a day or more than 5 pounds in a week. Those would be things that we'd want to know whether to start a diuretic or change the diuretics or increase them. So the next thing is the 2-gram sodium diet. So I'm going to kind of go across instead of down. We need to be careful about sodium in our diets. Sodium will basically counteracts what we're doing with the diuretics. If you consume a lot of sodium, then you're kind of fighting against what we're doing to try and keep that water weight off of you. So I tell all my patients you need to become label readers. So you need to look at the labels of the products that you're consuming. So for instance, I'll give you an example of a can of soup. Usually a can of soup, which I'm sure you and I could finish a can of soup, has 2.5 servings in it, and per serving it has 990 milligrams. So that's almost 1 gram or 1,000 milligrams. So if you look at that, and you shouldn't have, you should have definitely not more than 3 grams, but between 2 and 3 grams of sodium in a 24-hour period. With the 2.5 servings, you're consuming probably almost half, if not more than half, of the sodium that you should have in a day. Also, we had an interesting conversation with a patient who uses a lot of vinegars. She makes them and provides them, and anyway, balsamic vinegar is quite high in sodium. Some things I think if you look at the labels would shock you how much that is. So the next thing is to limit your fluids. We tell our patients to limit those to 2 liters. So if you think of a 2-liter pop bottle, soda bottle, that's how much you should be consuming in 24 hours. So that would be all liquids: milk, juice, soda, water. So we don't want you to drink a lot. I had a patient who was drinking about 5 liters or more of tea a day and wondering how come he couldn't keep his fluid under control. So we've got to do both of those things to try and help the heart. So the other thing is avoid sun and heat. I don't know if you'd know already, but if you don't, most patients have sensitivity to the sun and or humidity, and oftentimes both. And I think that's, that sensitivity, I think, comes from some of the medications you're taking as well as just the chronic heart failure. So heat is to be avoided, and just definitely direct heat. So oxygen is another important piece for patients who especially are at elevation or who require that. All of our cells need oxygen to function, and the right heart is very sensitive to oxygen. So again, another plug to wear your oxygen as prescribed. The next one is taking your medications. I love it there. I saw a poster on the freeway or a sign that said, a prescription is not suggestions, they're directions. So I have a patient who takes a trip to Salt Lake. It takes her about 4 or 5 hours to get here, and she doesn't take her diuretics because she doesn't want to pee every 30 minutes on the road. I understand that. but you put yourself at risk. It's important to take your medications as prescribed, because if you don't take them and you don't put them in your mouth, then they won't help you. So the other thing is to keep active. The old adage of, if you don't move, you lose. So another plug for pulmonary rehabilitation and remaining active and doing what you can do. The other thing is recognizing depression. There's a small study that was done out of Denver, and it basically talks about depression is highly unrecognized in patients, and then and just as highly undertreated. So I think it's important for us to recognize what depression is and how that would be in our lives, as well as to seek help and to talk to a professional who's not living your life. I think that's an important piece. There's probably other people you can talk to, but talking to somebody who doesn't live your lives and somebody who can provide you with skills to cope, I think, is very important. There's also a nice small study that was done several years ago on patients. It was a cognitive study, or how well your brain functions and processes, and we found that PH patients basically had lower abilities to remember and to cognate. Maybe because of low oxygen levels, we're not quite sure, but you're not crazy when you think, I just don't remember like I used to. Sometimes that's the disease process. So it's important to learn to recognize the clues from your body. Remember, if you overdo, you'll pay for it. I'm sure you've all learned that. If you haven't, you will. But if you feel good one day and you do too much, then you will pay for it for a couple of days. There's a lot of patients who explain to me that they have good days and bad days, or up days and down days. So how can I help my loved ones? I think caregivers or significant others will also struggle with your diagnosis. I think they should be educated about pulmonary hypertension and pulmonary arterial hypertension, and they should know your medications and why you take them so that they can be an advocate for you. I think it's always hard when somebody gets a diagnosis or a disease. There's so many different emotions that happen, but some things that I think will help with you and your significant others and the people around you is to learn to communicate with each other. That always seems to be an area of stress for patients. So remember, your caregivers are not mind readers. You need to verbalize what you need and what you want and how they can help. They need to know when to take over and when not to. I think being active listeners with each other and trying to really understand what each is going through and be sensitive to each other's emotions and feelings and what both of you are going through. I think it's important to look for ways to serve each other. I think that always helps, as well as do things together, find new things, and then do the usual things. I think caregivers specifically, for them, it's very similar to yourself. They need to take their medications. They need to keep active. They need to schedule downtime and time off. And if they have any form of depression or anxiety, they need to talk to a professional that's not living their life. So lastly, treasure the moments. This is a quote by Winston Churchill. Success is not final. Failure is not fatal. It is the courage to continue that counts. And I think that's a beautiful statement for pulmonary arterial hypertension patients and their significant others. So treasure the moments of every day. Be purposeful in living. Learn something new each day. Maintain and find new hobbies. Be involved with your loved ones. Be involved in your local community and also the PAH community. Help yourself and others. Give back to the community if you can. Have courage and hope. Keep moving forward. Don't be stagnant, and keep up the fight. Thank you.
All right. Thank you so much, Natalie, for leading us through that presentation. So as I mentioned earlier, we will be moving into the Q&A session now. So this will be your opportunity to ask Natalie, a PH treating expert, any questions you may have about PH. So we have started to receive some questions, but you are welcome to continue sending questions my way using the chat function. You also now have the opportunity to ask questions aloud via the audio function. So if you would like to do that, you can just go ahead and raise your hand on the web interface, and I will call on participants as the questions come in. So the first question we have, Natalie, is why is PAH more common in women than in men?
It's a good question. Actually, we have found it, and when I very first started in pulmonary hypertension, it used to be called basically a woman's disorder. It was a young woman's disorder between usually the ages of 20 and 30. And I think that was related mostly to pregnancy in women, and that's when we found the PAH, whether they were pregnant or had just delivered. Today we still know that that ratio is very high. It's basically 4 to 1. I don't know if we can completely understand why women are affected more than men. Some people have looked at hormonal level and differences in that, and maybe that making a difference in PAH. But it's still an area of research and focus, but we don't know completely. But we do know that it's young women and women are more affected. We've also had the Reveal Registry. I'm sure some of you have participated, or at least some people in the communities that you'll meet in pulmonary hypertension or arterial hypertension. That basically the average age of a patient today is about 48. So we're seeing, we can see PH in newborns, and we see them in even 80-year-olds. So there's really no one spared in developing pulmonary arterial hypertension, but we're seeing now more of an older woman rather than a younger woman.
Great, thank you. And it looks like we actually have an audio question. So Carolyn, could you please press *7 to unmute your phone?
Hello?
Hello.
Yes, I also have Ehlers-Danlos syndrome, and I'm wondering if there's any connection between Ehlers-Danlos and pulmonary hypertension.
It's probably a good question, Carolyn, for your physician. I'm not sure that I know the familiarity between the two diseases. But there are quite a few diseases that, especially if they're diseases of the vessels of the body, like lupus and scleroderma, that affect not only the vessels of the lungs, but they also affect all of the vessels in the body. So I think if it's a vascular or vessel disease, that can definitely be a contributor to pulmonary hypertension.
Well, it does sometimes affect the vascular system. It's a connective tissue syndrome in general.
Yes, definitely.
Okay. That's a very good answer. Thank you.
Thank you.
All right, great. So the next question we have is we talked about the different types of PAH in Group 1, and then we talked about the different types of PH in all of the other groups. And so the question is if all of the other groups can take the same medications as Group 1 for PAH.
That's a good question, and the answer is no. PAH has specific medications that really are targeted to the lung vessel disease that patients have. We want to dilate those vessels. Some of those medications are not appropriate and can make even the other conditions worse. So specifically, an example might be for patients who have left-sided disease, so their left heart doesn't squeeze and relax as it should. Those medications that we have for PAH would be more harmful than they would helpful. You've also got to realize that these medications for PAH are quite expensive, and so it's really important to differentiate between what your disease processes are so that we can treat them adequately. Diagnosis drives treatment.
All right, thank you. The next question we have that's come in is, are there any problems with taking other over-the-counter medications such as ibuprofen or acetaminophen? Perhaps a patient has a headache. Is there a problem with taking that with pulmonary hypertension in general, and is there a problem with taking them with your other pulmonary hypertension medications?
Good question. So when I started in pulmonary hypertension, we actually put most of our patients on a drug called Coumadin. It's something to help the platelets not stick together. And with Coumadin, there are so many drug-to-drug interactions. Today, Coumadin is not so much used in PAH, specifically just for PAH. Now, people who have chronic blood clots, that would be a different story. And so those medications, the ibuprofens and Advil or Aleve, those medications would be contraindicated, or you shouldn't take them because they have an increased risk of you bleeding than other medications. We tell our patients for headaches, Tylenol is a good option for the medications of PAH specifically. Some people don't get much relief from that, so that would be something that you would need to speak to your physician groups about. But acetaminophen, remember, you shouldn't have more than 3 grams or 3,000 milligrams in 24 hours. So you have to be careful even with the over-the-counters that you're using them appropriately. And for patients who do require narcotics, you've got to be careful that some narcotics have Tylenol in them. So you definitely don't want to use an over-the-counter Tylenol and the narcotic Tylenol products. You might get too much of it.
All right, thank you. The next question we have is if you could expand a little bit more on how to manage the side effects of PH medications.
Are we talking more headache and in that area?
Well, we had one question come specifically about edema, so not exactly a side effect of the medication, but a side effect of PH, but another more general question just about the side effects of the medications.
Yeah, it's interesting. I always talk to patients about, if the therapy is worse than the disease, then we don't want to go there. So, for instance, there's some people who have, they're more sensitive and they have migraine, headaches, and they basically the medications, at least one of those pathways, the PDE5s, we call them, that would be your Adcirca or sildenafil or Revatio. Those medications can worsen headaches and migraines in patients. So, we would try, I think, to take in consideration before providing those medications to you if you have those kinds of issues. So, and specifically related to edema, that is a question of heart failure. There are some of the medications, especially the ERA class, or that would be your Letairis and Opsumit and Tracleer. Those medications can increase the fluid that you have. I do think that the fluid is treatable, so that might be something to talk to your physician groups about, either starting diuretics or changing or increasing those diuretics when you're put on those medications.
All right, thank you. The next question we have comes from a patient who has PH, not necessarily PAH.
Correct.
And she's been told that PH isn't necessarily as difficult as PAH, so she doesn't take it as seriously. But so she wants to know if all of these other complications and the general path of the disease still applies to PH.
That's a very good question. So pulmonary hypertension is still serious, and it is something that needs to be treated. I think for patients, if you take a scenario of a patient who is maybe diabetic, an older patient, they might have some left heart dysfunction. Maybe this patient is obese and has sleep apnea. It's very important for you to treat those dynamics of that disease. In other words, get the diabetes under control, wear the CPAP and BiPAPs. So as well as do whatever you can to improve the function of that left heart. Take the medications that they provide to you. So, even though you have pulmonary hypertension, whatever causality is given that disease, you really do need to treat that disease and seek treatment and do the things that might help you overall. Because I think that you're still, patients who have these other diseases still have issues and still need help.
All right, thank you so much. So the next question we have is also related to the different types of PH. And so the question is if patients who are diagnosed with PH have to go through all of those same diagnostic tests as patients with PAH.
Remember, it's a diagnosis of exclusion, and so I think for us to determine the causality or to give you the correct diagnosis, some of the testing for pH might be very similar to what we would do with PAH. So can be some common testings. For instance, I think most patients who have shortness of breath, which you can have with pH, would be going through a diagnostic workup of the pulmonary function tests. I think most patients who have shortness of breath or chest pain or anything like that would be going through an echo and an EKG. A lot of our patients are sent to, we're a pulmonary group, but a lot of our patients are sent to cardiologists, and they're the ones who really identify because they've done that EKG and that echo, and they can see that there's an estimate that is high on that echo of the pulmonary pressures. So again, having to go to that left heart cath, I think would be common in a lot of the different pH groups, so that we can distinguish what that is and why those pressures are what they are.
Great, thank you. And we do have just a few more minutes, so if you have any final questions for Natalie, go ahead and submit them through the chat function now. The next question we have is about communication. And ever since this patient was diagnosed, she feels like her family tends to tiptoe around her. So how exactly would you recommend that she communicate to her family to just trust her that she's okay?
Yeah. I think it's really difficult to, I think that the caregivers or your significant others in your family, they're probably, just as worried as you are. And I think that worry comes out into, how can I help? And they overdo sometimes. And I think one of the biggest helps is to maybe yourself find help in communicating with them and helping them understand that there are things that I can still do. There are things I want to do and things that I want to try to do. So I think it's important to find the skills either through a professional or a therapist or somebody who does, you can even do some online communication courses. I mean, those things that allow you to verbalize how you're feeling to your family members is important. And I think you need to clarify when you first talk with them, which is, I'm struggling with this, and this is what I want your help, but your help is to allow me to do what I can do and feel like I can do and want to do.
All right, thanks. So we have one more question on the different types of PAH, and the question is if the different types of PAH associated with different conditions respond differently to the different medications.
So patient response is unique. In other words, we all respond differently. We're all just made up just a little bit different. But I can tell you the therapies for PAH are really directed at dilating vessels. So I think in that way it affects the body's systems the same in all of us. But our response to how they respond specifically can be very different. So there are some patients who will start an ERA and not have any benefit, or a PDE5 like the Revatio and Atcircus, and they might not have any benefit. We do have a new trial out called the Ambition trial that will be coming out in print soon, and basically in that trial they found that starting two medications at the same time, it was Letairis and Atcirca, that there was better benefit in morbidity and mortality as well as quality of life for patients. So, I think there's new and emerging things for patients and different ways that we can address starting and maintaining medications. So with the other things, if you had, for instance, scleroderma versus, idiopathic, I think that the way those drugs work in the patients is the same, but patients respond differently, and they have different varying degrees of illness. So there might be a patient population that doesn't do as well as another, and we do know that the patients who have HIV infection do the worst. That's what we've seen over these many years of time. But there's a gamut of how well patients do, and individually patients can do better than even a look at a group of patients.
All right, great. So we have two last questions, and I'm going to try to squeeze them in here real quickly. They're both about oxygen. And the first question was if only patients who have PH associated with a lung disease need oxygen. And then the other question was actually if everyone at some point will require oxygen, or if you might go through your entire life without necessarily needing oxygen.
Yeah. So I think oxygen is important. I think for patients who live at sea level, I think that they will get more benefit of not wearing oxygen for longer. That's what we've seen historically. Patients who live at higher elevations like in Utah, then you will probably likely have to go on oxygen sooner than you would in your disease. We do know it's progressive. So, but I think for patients who want to stay at those elevations, that oxygen, you have reasons that you'll be at whatever area you are. Not everybody's going to move to, California to have that, but some people will, and I think that there's benefit from moving for remaining off oxygen. I think most patients eventually will require oxygen at some point in their disease or their journey.
All right, thank you. And that's not just patients with an associated lung disease, correct?
No. That would be, I think, anybody that has pH and any of those WHO group categories can and may require oxygen at any point in time.
All right, thank you so much. So unfortunately with that, we are out of time today. So I just want to thank Natalie again for leading this conversation and remind everyone that the recording of this event will be posted on PHA Classroom in the coming weeks, so you guys can look out for that. And please also be sure to fill out the survey that pops up on your web browser as you're leaving the presentation. So thank you again, everyone, for attending this webinar, and I hope everyone has a great rest of your days.
Thank you.